Okay, so morning everybody. I'm Rob Burley. I'm Director of Campaigns, Care and Support at Muscular Dystrophy UK. Thank you very much for joining us this morning, and welcome to the first of two online seminars that we're holding today as part of our Muscles Matter online seminar series, Living with a Muscle Wasting Condition in 2020 and Beyond. In this series of 12 seminars, we're exploring what it's like to live with a muscle wasting condition in these unprecedented times. So 6 of the seminars are exploring specific conditions which are aligned to awareness days, weeks and months, and the remaining 6 are looking at a range of topics relevant to anyone affected by muscle wasting conditions. So far in the series, we've explored spinal muscular atrophy, Duchenne muscular dystrophy, mitochondrial disease, limb girdle muscular dystrophy, and living in a world with COVID-19. And we've also looked at assistive and accessible technology, education and employment. And in this session, of course, we're exploring Becker muscular dystrophy, marking the end of Becker Awareness Week. And then later this morning, we're also looking at financial support. After today, there are 2 further seminars on Charcot-Marie tooth disease and the impact of COVID-19 on neuromuscular services. And the link and the details of how to book for either of those 2 sessions or to view the recordings of the previous sessions is on your screen now. We're very grateful to Sarepta for supporting the Muscles Matter online seminar series through their generous sponsorship. MDUK are holding these seminars because for now we're unable to bring our community together through our information days, family fun days, or indeed even our national conferences and muscle groups. I think it's important though to highlight that our helpline remains available to anyone affected by muscle wasting conditions, and do please contact us if you have any questions or are in need of support. We can either provide the support directly to you or we can signpost you to an organisation that can. And the number and email address should be on the screen now, but you can call us on 0800 652 6352, or you can email info@musculardystrophyuk.org. And I'd like to take this opportunity to thank everyone who supported our work through volunteering their time or by making a donation. So we're hugely indebted to everyone who's helped us ensure that we can continue delivering activity like today's session, not least the panelists who joined us. And there's a vast array of ways in which you can support MDUK, so do please also contact us if you'd like to explore that or visit our website to make a donation. And a quick note on how you can ask questions or make comments throughout the session. So we've had several questions submitted in advance, which is fantastic, and we'll cover these as we go through the session. And we'd also like to incorporate some live input, and to do that we'll be using the Q&A function. So please type your question or comment and we'll feed them into the discussion. And to help us manage the technical side of the event, we won't be calling on questioners to ask their questions directly. And any questions we don't manage to cover or that we don't know the answers to, we'll seek to answer through the website afterwards. And a final reminder that we're recording the session and it'll be made available later this week. So to start us off this morning, I'd like to welcome MDUK's Director of Research and Innovation, Dr. Kate Adcock, who will introduce the research section of this morning's seminar. Kate, over to you.
Thanks, Rob. And I'd like to start by saying good morning to everyone and to introduce our 2 research speakers this morning. We have Dr. Thomas Gsokios and Dr. Federica Montanaro. Dr. Gsokios is a senior clinical fellow in heart and muscle at Guy's and Thomas's NHS Trust. Until recently, he served as clinical fellow in heart muscle disease at the Inherited Cardiac Conditions Unit based at the Barts Heart Centre, and held a post as an honorary fellow in cardiology with UCL, providing cardiology input to the Neuromuscular Complex Care Centre at the National Hospital for Neurology and Neurosurgery. And in a moment in this workshop, he'll be outlining aspects of clinical research focusing on how heart muscle and disease affects individuals with Becker muscular dystrophy. After Thomas, we'll hear from Dr. Federica Montanaro, who is the Marie Skłodowska-Curie Senior Research Fellow in the Developmental Neurosciences Department at the UCL Great Ormond Street Institute of Child Health. Federica trained in neurobiology at McGill University in Canada, after which she joined the lab of Professor Louis Kunkel, who discovered the dystrophin gene at Harvard Medical School. In 2005, she became assistant professor at the Ohio State University And in 2016, she came across with her family to London and joined the UCL Dubowitz Neuromuscular Centre as a senior lecturer. Her research focuses on the dystrophin protein and how it functions in the heart, which is especially relevant to the gene therapy and exon skipping treatments for people living with Becker muscular dystrophy. So now, Thomas, if I can turn to you for your presentation, and Emma will be driving the slides for you.
Thank you. Good morning to everyone. I'm very happy to be here as well. My name is Thomas Gsokios. I'm a cardiologist with a specialty in heart muscle disease. And I've been asked by the team in MDUK to provide a quick outline of what cardiac research is in Becker's muscular dystrophy. Well, the first question people may ask is why I'm here today. So if we can go to the next slide, we'll start at the beginning. We know that Becker's muscular dystrophy is a genetic condition. If you think of your DNA as the recipe by which your body is built, there's a spelling mistake in one of the ingredients called dystrophin, and that results in dystrophin being present in the body, in the muscles, in a lesser degree, or in an abnormal form, or completely absent as it happens in Duchenne's muscular dystrophy. So how does that affect the heart? Well, the heart is a muscle as well, and it's one of the hardest working muscles in the body. So with dystrophin lacking or not being sufficient, what happens is that as the heart is pumping, muscle cells fail, and they get substituted by scar tissue. And so we lose pumping function, and we get scar tissue accumulation on the heart muscle. And I'm just waiting for the next slide. As you see, that can happen in about 60 to 70% of patients with Becker's muscular dystrophy, and almost invariably in patients with Duchenne's. Now, having said that, the degrees of muscle disease vary substantially, so from very mild to more severe. But overall, there are some findings that suggest that cardiology input is required, and in order for us to be able to be more efficient in diagnosing your condition and treating it, we need to conduct research. So if we can go to the next slide, you'll see that when you attend your cardiology visit, you may be asked to enroll in some types of research. And these types are generally three. It's basic research, but Dr. Montanaro is a specialist in that and she will elaborate more. In clinical research, we mainly conduct either observational studies or interventional studies. And they have slightly different goals in this condition. So if we can go to the next slide. The next slide, please. So in observational studies, we try to get a better understanding of the natural history of the condition. And we also try to develop new tools to detect heart muscle disease, but these are tools that are already there. So we use imaging that's available in cardiology already, and we can see how this, how efficient it is in detecting heart muscle disease in muscular dystrophies. We also assess available treatment measures, medications that we use for other conditions previously, and try to assess whether they have any effect on this specific population. And obviously, by monitoring patients for a long period of time, we can identify any risk factors for the adverse events, so we can address them early on. If you can go to the next slide. In interventional studies, there is an intervention, either a medication, a device, something that we change to see whether it influences the progression of heart muscle disease. Does our intervention reduce symptoms, and does it improve quality of life? And of course, do we manage to reduce the risk of adverse events in the long term? These are all questions for these studies. And obviously, with newer treatments coming up to influence the progression of Becker's overall, does that have any effect on the heart? So if we can go to the next slide. I've got some examples of what has been conducted so far. So the next slide, please. The registers are highly important. If you look in your community, Becker's is a rare disease, and if you look in your community, there's either none or very few patients. So looking at the smaller picture in an isolated way, we cannot have a meaningful understanding of what's happening. But if we look at the big picture, a global picture, then we can have a good idea of how patients with Duchenne's and Becker's muscular dystrophy look like, what genetic changes are mainly involved, what targets can we identify to treat, and what do we need to do about them. And if we go to the next slide, our cardiology has progressed significantly lately, and it's allowed us to have more sensitive markers to detect heart muscle disease. So in all likelihood, when you visit your cardiologist, you will have an echocardiogram. And the echocardiogram is a very nice way to show pumping dysfunction. But if there's no pumping dysfunction, how can I know that there's no mild changes, mild, small amounts of scar? Well, echocardiography is getting more sensitive in picking these up. The gold standard right now, after recent research, is CMR, cardiac magnetic resonance. So an MRI scan can show us, even though the pumping function is normal, it can show us whether there's any scar tissue on the heart muscle. But by the time the scar has developed, there is already some progression. Can we pick it up earlier? So if we can go to the next slide. So these pictures, apart from being very colorful, they're very useful as well. They show us small amounts of scar. They can unveil small amounts of scar, even though they're not visible to the naked eye. So technological improvements and have helped us become more sensitive in picking up even the subtle changes. And by enrolling patients in research, we can identify what the meaning of these very early changes is. And next slide, please. Now, obviously, once we find that there may be a heart muscle problem, we need to intervene. And so far, we've had medications that were used for conditions already existing. Pumping dysfunction can occur for many reasons. In the broader population, the most frequent cause is having a previous heart attack. If we go to the next slide. Researchers used beta blockers and ACE inhibitors previously to see whether they have any effect on the pumping function. So we knew that this worked in people who have had heart attacks. We knew that this worked in people who had pumping dysfunction for other reasons. But did this apply also to patients with Becker's and Duchenne's? So if you look at the blue panel, you will see that using beta blockers and ACE inhibitors did indeed help improve the pumping function. So the pumping function went from a mean of 45 to a mean of 52, for example, whereas patients who received placebo, not a medication, they exhibited a drop in the pumping function. Next slide, please. And later on, when we were treating patients with pumping dysfunction for other reasons, came eplerenone. It was a relatively newer medication, but we needed to confirm whether this effect was also evident in patients with muscular dystrophies. And indeed, that was the case. So people who were taking eplerenone showed the greater stability of the pumping function over time compared to people off it. So with research, we managed to confirm that medications that were previously used for other reasons are also beneficial in patients with muscular dystrophies. Can we go to the next slide, please? But does this matter? The numbers sometimes may be improving, but does this reflect into better long-term outcomes? So now that we're managing to study bigger populations of patients with muscular dystrophies, what we have found is that there's a nice correlation, there's a direct correlation between the amount of scar tissue that accumulates on the heart muscle and the pumping dysfunction. And with the use of, if we can inhibit the development of scarring on the heart muscle, this seems to reflect to lesser events. So if you look at panel C on the right, people who had complete absence of any scarring on the heart muscle had almost no effect, no events, cardiovascular events throughout their life. Whereas in patients where there was presence of scarring, well, there were some cardiovascular events. If you can go to the next slide, please. So this so far has been about things that have been established, but the future, there's been increasing interest in research in the muscular dystrophies, and particularly in heart muscle disease. So the future holds promising treatments. So if we can go to the next slide, I'll just focus on, I'll just mention why it takes so long these novel therapies to come out. Developing a new medication and getting it into clinical practice is a very long process. And the reason for that is that first we have to identify whether that novel compound works in the lab first at a microscopic level. And then we start trials on humans. These trials focus primarily in phase 1 and phase 2 on the safety side of things. So no drug will come out unless it's safe in these first 2 phases. And from phase 2 onwards, we try to measure the effectiveness while keeping an eye for side effects still. Now, you may recognize these phases from the news. Some vaccines for the coronavirus are in phase 3 right now. And when they come out, or when medications come out, monitoring doesn't stop there. There's always phase 4 where we monitor for long-term side effects. So this is a process that takes long, but if you go to the next slide. And next slide, please. Hello? Can you hear me?
It looks like we may have lost Emma, who's dealing with the slide. Bear with us. Sorry.
I can share my screen.
Yeah, seems like Emma has got a technical problem at the moment.
I can share my screen and continue from this point on if you want.
If that's possible, that would be fantastic.
I'm not able to share my screen, I'm afraid.
Let me see, I have your slides up as well. Bear with me 1 second. Oh no, I can't share my screen either. Emma, are you able to go back to the presentation or allow me to share my screen?
Can you see the presentation?
It's loading.
Can you hear me?
We can hear you now. Yeah, hi Emma. There we go.
Although it's a bit fuzzy.
Okay, can you see the presentation?
It's a bit fuzzy, so text is not visible.
I'm going to try switching to a different internet. Hang on 1 minute. Hopefully I don't disappear.
While you are doing this, Emma, just
bear with me.
Participants and attendees, that there is a function on the bottom of your screen. If you hover your mouse button for Q&A, do feel free to ask some questions, and we'll address them later on. That's clearer now, Emma.
Mm-hmm.
Thank you.
So with this long process has allowed us.
Yeah, good. Okay.
Yeah. So this long process has allowed us now to be able to test some new treatments. So eplerenone is promising, but it's hello? Can I continue? So eplerenone is promising. It's showed some improvements in the general functional status of patients with Becker's muscular dystrophy, but it's only focused on some specific population, about 10 to 15% of the whole population who carry these nonsense genetic changes. So far, we don't have anything on the cardiac side of things, but surely there will be something tested in the future. Now, eplerenone is also promising. It's an antifibrotic substance. There's an ongoing trial which is currently recruiting in the United States, and this, as I said, because SCAR does play a role in heart muscle disease, should come back with some information on what the cardiac outcomes are. I have lost the screen.
We seem to have lost, yeah, the Emma completely. And I still can't share my screen. Are you able to continue talking a little bit without your slides in front of you, and we'll...
Yes, yeah. So Well, these I showed you that slide before, and we had I had Atalur and epicatechin as green because they seem a bit more promising from the clinical side of things in the heart muscle aspect of things right now. The yellow panels were discussing about microdystrophin and the exon skipping therapies. Both of these do not have any cardiac effects demonstrated, but they are highly promising in the future. If we can go to the next slide. Next slide, please.
I think she's trying. I think we've lost her again.
That's fine. I'll just
Can you all see that?
We need the next slide, Emma. It's gone again now.
So sorry.
There we go.
Can you see that?
Yeah.
So some of the more eagle-eyed viewers may have noticed that they keep mentioning Duchenne's muscular dystrophy, whereas this is a talk for Becker's. There is a reason for that. There are two reasons for that. So researchers like to enroll large populations. So it's very easy to conduct a study in the general population, for example, in high blood pressure or in high cholesterol patients, because this is quite frequent. Neuromuscular conditions are obviously rare, and Duchenne patients are much more frequent and easier to study. The reason for that as well is that the presentation in Duchenne's muscular dystrophy is much more uniform. So most patients will have uniform findings, same degree of muscle disease, whereas in Becker's, when you enroll a specific population, some patients may have no disease at all, some people may have more severe disease. And researchers tend to focus on uniform populations because when we're looking for changes, we want to make sure that this is because of our intervention and not because the population is different by definition. However, most of the practice right now in Becker's derives from either the general population or Duchenne's. So in a downstream fashion, patients with Becker's muscular dystrophy are benefited from this practice. If we can go to the next slide. And this is just to show you how things go downstream from the general population. If we look at the heart failure treatments, medications like ACE inhibitors, beta blockers, eplerenone were used in the general heart failure population in the late 80s to early 2000s. And in the past decade, we've started employing them in Becker's muscular dystrophy patients with success so far. And since then, there have been new compounds developed that certainly have shown benefit in the broader heart failure population and could in the future show significant potential in the Becker's population as well. Next slide, please. So with research, we've achieved to obtain new biomarkers and recognize heart muscle disease earlier. We'll be able to conduct better trials with more sensitive markers. There are new therapies in the pipeline, but so far there's little, if any, information on heart muscle disease. There is, however, increasing awareness on this topic, and it's certain that the future will hold a lot more research to come and quite possibly much better outcomes. Thank you for your attention, and I'm here to take any questions.
Thank you so much, Thomas, and thank you for bearing with us, everyone, where we have these little technical glitches. It wouldn't be a Zoom call if there wasn't some kind of a technical glitch. So, we're getting used to this in this new way of working. Just to remind everyone, as I say, do feel free to ask questions in using the Q&A function. If you hover your mouse, if you've got a laptop, I'm not quite sure how it works on iPads and phones, but you should be able to see a Q&A function. Emma, do you think that we could go straight into Federica's presentation? This one is pre-recorded, so fingers crossed that it will play through.
Can you all see that?
Yep.
Okay, I'm going to press play.
Good luck.
Good morning. My name is Federica Montanaro, and I am a researcher at the UCL Institute of Child Health. I have a long-standing interest in heart disease in Becker muscular dystrophy, and today I want to give you a little bit of a flavor of some of the research in this field and what my team is currently investigating thanks to funding from MDUK. Heart disease affects over 70% of patients with a diagnosis of Becker muscular dystrophy. So the good news is not everybody will develop heart disease. And the second good news is that there are medications currently available that can help manage heart disease, but they do not completely cure it. And some patients might go on to need a heart transplant. A curious feature in Becker muscular dystrophy is that it is possible to have very mild or no muscle weakness, yet still develop severe heart disease. There are many questions that remain unanswered, such as what causes heart disease in Becker muscular dystrophy? How can we identify patients most at risk of developing heart disease? And can we improve treatment of heart disease? At this point, I would like to introduce you to dystrophin depicted here as a colorful rod. I want you to think of dystrophin as having one main function: to act as an anchor that keeps important element in the right place for them to function inside heart cells. There are two major anchor points. One is at the start of the protein, shown here in orange, and the other one is towards the end of the protein, shown in red. Dystrophin is made by the DMD gene, and we know that if a mutation prevents dystrophin from being made, a patient is diagnosed with Duchenne muscular dystrophy, that is the more severe form of the disease. Instead, if a mutation allows dystrophin to be made, a patient is usually diagnosed with Becker muscular dystrophy. Therefore, we can use information about a mutation to gain insights into disease severity. So for several decades now, researchers have been asking whether we can look at a mutation that causes Becker muscular dystrophy and whether we can tell what is the risk for that patient of developing severe heart disease. So a study in 1999 by the group of Francesco Montoni discovered that there are mutations that only prevent expression of dystrophin in the heart, while all other muscles do have dystrophin. As a result, those patients have no or very mild muscle weakness, but they develop severe heart disease at a very young age. There are other mutations that will not remove an anchor point, but will weaken it. These mutations mainly affect the anchor point that is at the beginning of the dystrophin protein. These patients typically develop heart disease in their 20s, and they also suffer from muscle weakness based on a study we conducted. There is yet another kind of mutation that destabilizes dystrophin in such a way that there is not enough dystrophin protein present to anchor the elements in place. With our collaborators, we have used computer modeling to see how these mutations might make dystrophin unstable. This region here of dystrophin is depicted here via computer modeling and is predicted to look like an elongated straight rod. Our computer modeling of a very typical and common mutation that is found in Becker muscular dystrophy is shown here. These are patients with deletions of exons 45 to 47. These deletions are expected to make the protein bend. Patients with mutations that cause this type of bending typically develop heart disease about 10 years earlier than patients with mutations that keep dystrophin straight. So what have I shown you so far? When we look at what causes heart disease, I have told you that the type of mutation can play an important role on how early heart disease starts. At the more severe end of the spectrum are mutations that completely prevent expression of dystrophin in the heart. Then come mutations that weaken the important anchoring functions of dystrophin. And finally, there are mutations that decrease the amount of dystrophin that is available by making it unstable. And the severity of heart disease will in part depend on how much dystrophin is left in the heart. Can we identify those patients that are most at risk of developing heart disease? Well, it looks like some mutations do correlate with heart disease, but there is a lot more we need to learn before we can confidently use mutations to predict the risk of heart disease for individual patients. Now we'll give you here one example of some mutations that fall within this region here of dystrophin. They do not destabilize the anchor points, and they also do not destabilize the production of the protein. Yet, patients do develop heart disease, usually past their 40s. These mutations seem to impair an unknown function of dystrophin that is important for the heart. With funding from MDUK, we have therefore been looking at what other functions dystrophin might be playing in the heart. What we have found so far indicates that dystrophin is not just an anchor, but may also act as a sensor or antenna that might be able to detect when the heart is under stress. It then relays a signal inside the cardiac cell that activates a little protein called ERK. When ERK springs into action, it is known to help the heart survive and makes it stronger in order to handle the stress that it is facing. We are in the process of trying to identify what part of dystrophin is important for this antenna function so that we can predict which mutations will impair the activation of little ERK. To do this, we are using micro and mini dystrophin that have been created to help develop gene therapy for Duchenne muscular dystrophy. They are missing different pieces of dystrophin. To date, we have completed work on the shortest one shown here. This is a microdystrophin that is similar to the one currently in clinical trials for Duchenne muscular dystrophy. Our tests so far show that this microdystrophin is not able to activate ERK properly. What I'm showing you in this graph is that we can measure the activity of ERK, and we have found that ERK activity is decreased by 3-fold in hearts that lack dystrophin, like Duchenne muscular dystrophy, or in hearts that express this microdystrophin. So now the big question, can we improve treatment of heart disease? I believe the answer is yes, and in some cases we might be able to use treatments that are being tested in Duchenne muscular dystrophy patients if they are proven safe and effective. For example, if we take mutations that cause a lack or low level of dystrophin in the heart, we could, for example, think about whether these patients would benefit from gene therapy or exon skipping. But these types of treatment will not benefit all patients. For example, we might need to find drugs that can help activate the signal that is not being properly transmitted in some patients. And therefore, more drug development is going to be needed. I will stop here, and I would like to thank you all for your attention. And I would also like to thank MDUK for funding our work. And these are Elena and Daniel, who are being funded by MDUK to work on dystrophin signaling functions. Thank you very much.
Wonderful. Thank you very much, Federica, and hurrah for the technology working that time. That's great. So we've had a couple of questions in the time before the meeting started. So don't forget that there's a Q&A function, and I've seen that we do have a couple of questions there. But first of all, if we can just turn to some of the questions we had submitted in advance. And you've touched on this a little bit already, Thomas, and Mark, I don't know if you maybe would want to come in also about medication for Duchenne and other neuromuscular disorders that can be sort of filtered down and used for those that have Becker muscular dystrophy. Thomas, maybe if I can turn to you first.
So right now, the mainstay of medical treatment for heart disease in Becker's has already been tested thoroughly in patients with Duchenne's. And actually, many of the newer trials coming up include populations of both conditions. So obviously, in order to role in a trial, there needs to be a confirmation of the genetic background of the condition, and also confirmation of of the required degree of heart muscle disease for each distinct trial. So there are trials, for example, there will be research projects in patients who have no evidence of disease, for example, little evidence of disease, or severe disease. But already clinical practice has shown us that research, even if it's only focused in Duchenne, goes downstream and is applied in patients with Becker's. And now, having a purely Becker's population might not be that frequent. And the reason for that is that patients, as I said, are very variable, and they're very few as well. Now, the newer treatments that, even in the current times, even patients who may develop symptoms and signs of what we call heart failure may receive even newer treatments that have been developed in the even bigger population of heart failure for other reasons as well. So in the past few years, we had at least 2 new medications coming up, which have shown significant promise in patients with other reasons of pumping dysfunction, and they have been helpful in treating symptoms and have had benefits in terms of long-term outcomes. So if a patient individually fulfills criteria to receive one of those, they could discuss this with their cardiologist, and they could benefit from these.
Wonderful, thank you. Mark, and then I'll come to Federica as well. I think you might be able to say a few words. Mark, I'll introduce you in a moment. Sorry, I'm coming in.
So my name's Mark Roberts. I'm an adult neuromuscular neurologist working in Manchester and Oswestry with Nick Emery, the physio, that we'll be talking later. And I just make a few points about Becker and the heart, and very much to emphasize Thomas's point. So Duchenne is common. Duchenne is severe. Duchenne is a condition in which the endpoints in clinical trials therefore can be really robust: survival, respiratory failure, cardiac involvement, all very, very robust measures. Clearly, however, that information may trickle down into Becker for sure. And I think that Thomas is absolutely right to emphasize, as was our research colleague, the major involvement of the heart in Becker. We've actually transplanted 7 patients in Manchester with Becker who actually had remarkably good skeletal muscle strength, cardiac transplant. So I think there will definitely be a trickle down into Becker. And I think one of the main focuses must be on cardiac outcomes in Becker, and not just rather crude measures like 6-minute walking times and delays in loss of ambulation, because that could take an enormously long time to demonstrate in Becker. So I'm very excited about the heart. I've really enjoyed those first 2 presentations.
Wonderful, thank you. And Federica, I don't know whether you have any comments.
Yes, I just wanted to add to something Mark said. There is this striking difference between skeletal muscle, muscle weakness and heart disease. And I agree with him that we need to just separate the 2 when we look at outcomes, especially for Becker muscular dystrophy patients, because the mechanisms of the disease may be very different, and therefore the treatment that works for muscle weakness may not quite have the same effect on the heart. And I wanted to emphasize from my presentation that what the picture that is emerging by looking at these different mutations and starting to have enough patients now to start looking at, if you have this type of mutation, what happens to your heart disease specifically. What we're learning is that the mechanisms of disease, even within the Becker population, are different. And therefore, the disease is going to be different. And the treatments that we need to work best with those patients are going to need to be tailored a little bit. So the next question, also the next level of complexity, if you want, is going to be, if we do have a treatment or a drug that comes out and has worked in Duchenne patients, and we want now to test it in Becker patients, there isn't just the factor that Becker patients are less, that they're more heterogeneous, but you need to start to know which ones are going to actually benefit from this drug, which is going to be an even smaller group. And that's where we're trying to get to that with some of the research that we're doing and some of the genetics to sort of identify, you're going to be benefiting from this drug and this treatment. Maybe this other patient, because of the mutation, it's not going to be the best. And some of these treatments, like gene therapy, you can't reverse. Once you have done it, you are stuck with it. Others, it's not like a drug you can stop taking. So we need to be really getting a lot more information before we move on with these. And it's difficult, it's tricky.
Thank you. I think that's a very good point, that, you know, the numbers of patients get smaller and smaller and smaller as you look at particular different subtypes of particular different causes. That's very helpful. Thank you.
If I can make a comment, Kate.
Oh, please do.
There are actually some questions. A gentleman mentioned that he's on medication called Entresto and he's received a defibrillator. This is something I did not really give much. I didn't discuss it a lot, but I just wanted to highlight this sort of two-pronged approach in treating heart muscle disease in patients with Becker's. So one part, what's already in place, actually comes from treating heart muscle disease as a whole. So patients who develop pumping dysfunction may discuss further treatments like defibrillators, heart transplant, as Dr. Roberts mentioned, medication, newer medications like Entresto, for example, on a case-by-case basis, because they exhibit pumping dysfunction and symptoms because of that. And then there's the other approach, which Dr. Montanaro outlined very well, is the approach of treating Becker's as a primary condition and assessing what effects this may have on the heart. Some treatments may have effects on the heart, but some others, for specific reasons, may actually have no effect. So from a cardiology point of view, right now current practice relies mostly on practices from a broader population of heart muscle disease, with fewer applicable treatments in terms of Becker-specific disease. So yes, it's quite possible that when you visit your cardiologist, you may discuss about treatments that are not specific to Becker's, but come from a purely cardiac point of view.
Fantastic, thank you. And we've had a question that was in advance, but actually links to one of the questions that we've been asked this morning already. Are there any new medications that are being used or on the horizon to help those with Becker? And that kind of links, I think, to there's a clinical trial that started in the summer in the USA. It's a phase 1 clinical trial for something called EPM01. And I guess a question about, does anyone have any information about that and how that might be taken forward? I mean, I guess that speaks to the phase 1. It's an open label clinical trial. And you've already shown, Thomas, a little bit about how the trial process is a very long, drawn out one because of the care that needs to be taken around safety. But I wonder if you've got any comments, Thomas.
Well, I showed on my last slide, this was a slide from 2017 showing how many trials are in which phases. Unfortunately, through this process of passing all through these phases, many medications don't find their way into phase 3 and obviously phase 4. And the reason for that is that a phase 1 trial is performed to mainly determine what dose of the medication would be effective, would it have any effect in a small population, and would it be safe. Now, for most trials stop because there's no effect. It's a sort of a trial and error thing. We try a compound, we see whether it works, and if there's no meaningful effect, there's no point in advancing to the next stages. So I wouldn't really stick to this specific trial, but as a general comment, I would say that in the same stage, there's probably multiple trials around the world that we may know or will know about in the future if they start showing promising results and being able to advance in phases 2 and 3. But this is a long timeline. It's usually above 5 years, almost sometimes 10 years until this into a phase 4 drug.
Mhm.
So it's promising, but it's not something coming up very quickly.
Yeah, and as you comment that these are trials. They're not guaranteed to go through, and it can be very, very disappointing for individuals and families when things don't progress, but they don't progress because they're not working, or they've been found to be not safe, and it wouldn't be ethical to take things further forward, despite the obviously, you know, the hope that we all have that these things become treatments in the future. I think we've probably covered. Oh no, there's another one here, sorry. Is there any clinical data regarding the relationship between utrophin expression level and the disease severity and muscle weakness and heart failure? And is there a negative or positive correlation? Utrophin is a molecule very similar to dystrophin. It's expressed very early as a baby is developing, and then it usually gets switched off and replaced by dystrophin. But I don't know whether Federica or Thomas or maybe Mark, you have any comments or thoughts on that? I'm not seeing any of you. I'm using Federica.
Maybe I can say something. There isn't really any good evidence at this point that utrophin help in humans, at least for the heart. In part, it's very difficult to assess because we don't have access, and it wouldn't be really feasible to have cardiac biopsies. It's possible to look and do these type of studies in skeletal muscles because you can access them. But a cardiac biopsy from a human patient is really difficult to obtain, and that's really what you would need to have in order to be able to look at utrophin levels in the heart. From mouse studies, the mice that were generated that overexpress utrophin do not overexpress it in the heart, so we don't really know about this. The other thing that is it's one thing we are starting to look at. It's not easy, but it doesn't look like there is a whole lot of utrophin inside heart cells. There is utrophin in the vasculature, and it plays an important role there. So it's possible that when you look at mouse studies where you are lacking one copy of utrophin, it's possible that you get more severe heart disease because of the effect on the vasculature to the heart. So this is a question that still needs to be sort of resolved. It's not entirely clear.
Right.
So from a research point of view, there are still a lot of questions, and I wouldn't be able to really say it one way or another. That there's
Great. Thank you. There's a really great question here about the fact that the dystrophin gene, the DMD gene, is very large. This means that genetic mutations with this gene could be in sort of any place, and the chances are that even in the general population, there could well be mutations that go undiagnosed. And I suppose the question really is, what scope is there for collecting genetic information from the general population to allow deeper research into the effects of particular mutations? I think that's a fantastic question. I don't know whether any of you have any thoughts on that. I guess genetic testing and looking at genes is very complicated and very complex and time consuming, but I think that's a really great idea and a really great question. Thomas, you've unmuted yourself, so I'm assuming you have thoughts.
Just from the clinical point of things, I just wanted to say that we now have a nice understanding of what patients, what mutations there are there. So just name the mutation. However, it's a much more complex process to understand what the impact of genetic change is. because it's not as simple as I described it at the beginning of my presentation. I think that's where basic research like Dr. Montanaro is doing is helping us understand all the implications on all the mechanism that this genetic change is involved in. And so it's not a matter of figuring out which mutations there are there. I think we've done that through registries, but what each individual mutation, what mechanisms does it influence, that's a very much bigger discussion from the clinical point of things, at least.
Sure, sure. I'm mindful of time and the fact that we have a fantastic panel here, and it would be wonderful to hear from them as well. So we will keep answering research questions, but I'd like to move to the next part of the discussion. So thank you both, Thomas and Federica, for your input so far. I'm sure we'll be hearing more from you as we move through the rest of this session. But I'd just like to start the next session by introducing the rest of the panel. As you've already heard from Dr. Roberts, but let me introduce him now more formally. Thank you for joining us. As he's already said, Dr. Roberts is a consultant neurologist at the Salford Royal NHS Foundation Trust, and also has links to Oswestry. He qualified in 1989 with degrees in medicine and physiology, and completed his speciality training at the Walton Centre for Neurology and Neurosurgery in Liverpool. In 2000, he was appointed as consultant in neurology in Manchester, specialising in neuromuscular disease and transition care. And in 2002, he established the Northwest Neuromuscular Network with paediatric colleagues, which was awarded National Centre of Excellence in 2017. And I know he has a particular interest in pain as well, in neuromuscular conditions, and he'll tell us a little bit more about that in a moment. Nick Emery also has had a bit of an introduction already. He's a neuromuscular specialist, clinical specialist physiotherapist at the Robert Jones and Agnes Hunt Orthopaedic Hospital in Oswestry. He qualified as a physiotherapist in 2005 after being a firefighter in London for 18 years, which is quite a career transition, I would say. And he spent his entire physiotherapy career in neuromuscular disease. And in his current role in Oswestry, he works as part of a multidisciplinary team with 2 neuromuscular consultants, 2 physiotherapists, a clinical nurse specialist, a care advisor, a clinical psychologist, and caring for both adults and paediatric patients. He runs independent physio clinics, providing advice and care for musculoskeletal pain in neuromuscular disorders, and provides exercise advice. And he's also involved in pharmaceutical and clinical research projects. Moving on to Wilma Stewart. Wilma is a specialist advisor in neuromuscular conditions at Queen Elizabeth University Hospital and Royal Hospital for Children in Glasgow. She was actually one of MDUK's original care advisors and joined MDUK in 2008. She then transitioned to the NHS Greater Glasgow and Clyde around 7 years ago, and remains a part of the neuromuscular team at the Queen Elizabeth Hospital and the Royal Hospital for Children in Glasgow. Wilma supports patients and families at the point of diagnosis and at times of change. And she helps to enable the independence of individuals by helping them achieve their educational goals, getting appropriate housing, and pursuing their dreams and aspirations. And finally, last but by no means least, is David Gale. David is an MDUK volunteer who is living with Becker muscular dystrophy himself. He's a full-time civil servant from Templand in Dumfries and Galloway. He was diagnosed at the Newcastle City General in 1988 when he was 5 years old, and has been involved with Muscular Dystrophy UK on and off his whole life. And he was part of the launch of Trailblazers when it was launched just over 10 years ago. And he's also been an amazing and successful campaigner in the past and has won awards for these activities. David's a member of the Muscular Dystrophy UK Scottish Council, and also a member of the ITV Borders panel, diversity panel for Cumbria and the south of Scotland, which is absolutely fantastic and builds on that campaigning work. So now I'm going to invite each of our panelists to make a few remarks about their work and how they support people living with Becker muscular dystrophy. And then we've got some more questions coming in, which is fantastic. So we'll have more of a discussion in a short while. So Mark, if I could start with you, I wonder if you could give us an overview of the kind of support that service such as yours provides people who are living with Becker muscular dystrophy. And I think you've got some slides and you could talk to us a little bit about the pain management aspect.
Yes, thanks very much for the invite, Kate, and incredibly impressive to see so many people on this early on a Saturday morning. So I'm fortunate to work between Manchester, predominantly the Children's Hospital in Manchester, and working with two colleagues in Oswestry, which is a fantastic MDT approach, which is definitely what patients with BMD want. And I just wanted to make a few points about pain. Clearly the word dystrophy, meaning difficulty growing, emphasizes the wasting and the weakness of patients with muscular dystrophies of different types. But what I wanted to do was to emphasize the pain. Can you see my slides? Perfect, great. Next slide, please. So pain is very subjective, but extremely difficult to actually define. The International Association for the Study of Pain suggested it was an unpleasant experience occurring in an emotional context that reflects an actual or a perception of tissue injury. Very worthy diagnosis, but as C.S. Lewis put so much more succinctly in his monograph on pain, pain is suffering. And of course, suffering is extreme and hugely affects quality of life. Next slide, please. There are, however, many different types of pain. So pain can arise because of normal mechanisms of pain sensing, which can be adaptive and protective, for example, to trauma, but ultimately can become dysfunctional. Pain of neurological origin is often neuropathic and has a shooting, burning, or stabbing quality that reflects abnormal nerve functioning. For example, in patients with neuropathy, a generalized problem that's frequent in patients with diabetes. But crucially, increasingly, we believe that nerve mechanisms may contribute to the pain even in primary muscle diseases. And of course, and this is where physiotherapy is so crucial, it can be biomechanical, a complication, for example, of scoliosis or vertebral fractures that are so frequent in many patients with muscular dystrophy. Pain being subjective is a really difficult thing to measure, and there are various scales that one can use. So, for example, visual analog scales, Likert scales, where you obviously indicate how bad the pain is, how frequent, how long it is. And body maps are increasingly useful and are going to be used increasingly in clinical trials of pain, including in muscular dystrophy. The Gale scale was developed actually in the States, and it talks about various hives and other forms of pain. And these are probably going to be increasingly important in muscle disease. But obviously we need to think about the impact of pain on quality of life and indeed mental health. And there are various useful scales that can capture these things. Next slide, please. Pain is incredibly complicated, but incredibly frequent, and is actually the most common clinical problem across a whole range of neurological disorders. So multiple sclerosis, Parkinson's, neuromuscular diseases that we're focusing on today. And large surveys have shown that up to 80% of patients have chronic pain, that is daily pain for 3 months or more of their life that they can remember, of a severe nature. Next slide, please. And when we focus on pain in muscular dystrophies, it is actually a very common issue. So, for example, in facioscapulohumeral muscular dystrophies, often biomechanical around the shoulders, but often stabbing and shooting, reminding us of nerve involvement in muscle disease. Certain of the limb girdle muscular dystrophies can be very painful, and this is an important marker, for example, for those with ANO5 mutations, in which the muscle biopsy can be remarkably unremarkable, but the mutation is then found when you search in these patients with painful teenage onset myopathy. In myotonic dystrophy, a condition characterized by muscle weakness and stiffness, pain is actually a remarkably prominent feature, and many have actually quipped that perhaps we should rename dystrophin myotonica type 2, which is also called proximal myotonic myopathy, proximal myalgic myopathy, to emphasize how frequent pain is in these patients. But of note, it's not just these conditions. It is Duchenne and it is Becker patients who have a lot of pain too. Next slide, please. And there have been a number of very good pediatric studies that have looked at this in Duchenne and Becker patients. And as was alluded to before by Thomas, it's often quite difficult to do studies of pure Becker. But if you look at these studies, you'll see that there's significant amounts of pain in Becker patients and not just Duchenne. And crucially, this is often underestimated, not only, as you'd imagine, by the rushed physician, but even by the parents. When you actually talk to the children about their experience of pain, parents often don't realize how severe the pain is. Next slide, please. Christian de Huda up in Preston did a very good study as a pilot and as part actually of the Northwest Muscle Network to look at pain in Duchenne. And he found, and this is very humbling, how many physicians will underestimate pain in Duchenne. And as Kate Bushby and others, we have emphasized, we really do need to look more at pain in our patients and focus on it and not just look at muscle function, respiratory function, and heart failure, crucial as those all are. Next slide, please. Biomechanical aspects, I would imagine Nick will talk a lot more about. Sorry, that's flicked off for me now.
Yeah.
Yep, great. I think Nick will talk more about, because you really do need an MDT approach to try and help these issues. Next slide, please. And this just shows you the sort of abnormal gait problems, the sort of Trendelenburg gait that you frequently get in neuromuscular disease. And just imagine all those secondary biomechanical problems at the hips, at the knees, and higher up in the spine that contribute to the pain in neuromuscular conditions such as Becker. Next slide, please. And how are we going to try and help this syndrome? Well, obviously we need to understand it best first, and physiotherapy assessment and gait analysis can be very useful, but specialist orthotics can be useful. Scoliosis surgery not only helps, of course, to maintain the better position of patients in wheelchairs, improves their respiratory function, it significantly can reduce pain, but it can be complicated by leg problems, including rod failure. We obviously have to think of pain in our patients as potentially indicating they may have had vertebral fractures, and this is not infrequent, obviously in Duchenne, but actually frequent in patients with Becker. And if detected early, there are now clever ways to put cement into the crushed vertebra at an early stage and reduce significantly the chance of long-term pain. But there are often other sources of pain as a consequence of the muscle disease rather than as a direct affliction of it. So for example, meralgia paresthetica, a horrid burning pain down the outside of the thigh that reflects a trappage of a nerve locally in the groin. And of course, the local pressure sometimes from wheelchairs can aggravate this. Bursitis, that is an inflammation around a joint in the hips, and especially the knees, can contribute to pain. And these conditions are very treatable if identified. And then, of course, because of the long-standing biomechanical problems, early arthritis in the hips and knees, and indeed in the lumbar spine, all of which can be addressed typically by pain relief procedures. Next slide, please. But what is the mechanism that actually fundamentally underlies the pain at a local muscle level? This is a scan from a particularly severely affected patient with Duchenne. It's a cross-section through the thighs. On the outside, you can see the skin, and underlying that, you can see the white of the natural fat. Now, muscle should look like a good piece of steak, and you can see islands of preserved muscle with a nice dense structure. But much of the rest of the muscle belly, both in front and in the hamstring muscles behind in this patient, you can see the very white appearance indicating fibrosis and fat deposition. Because of this problem of different muscle groups getting affected to different degrees, there's a major problem of differential shearing. That is, different muscle groups are trying to overcome the patterns of weakness, and that causes undue mechanical force. Frequently, and not just in myotonic dystrophy, patients with Becker will describe locking in their hands. This almost certainly means delayed muscle relaxation or myotonia that is frequently painful. As we know, particularly from Duchenne, inflammation in the muscles is actually a frequent feature, and hence the early use of steroids that may actually slow down some of the loss of breathing capacity. So inflammatory mechanisms are probably very important in the maintenance of pain. Many primary muscle diseases also affect other crucial cellular systems, and in particular mitochondria, the powerhouses of the cells, if you like, the furnace in which energy is generated. And these are affected not only in primary mitochondrial diseases, but metabolic conditions and even muscular dystrophies. But it has to be said that in many patients, we really don't have a good understanding of pain. Next slide, please. Interestingly, there's an increasing belief in some rare conditions that the pain in the muscles, the myalgia, the myos, the muscles, the algia, the pain, may actually be of nerve origin. And this looks at altered nerve respiratory tone into muscles in patients with Pompe disease, strongly suggesting that there may be abnormal mechanisms of nerve activation and perhaps also the central processing of pain in conditions that we traditionally have only thought of as a primary muscle disease. Next slide, please. Now, a condition that we think of as being very, very much a muscle condition is a very common condition, particularly in women, though can occur in men as well, namely a suffering, a pain, fibromyalgia, affecting the bones and the joints and the muscles. But interestingly, Anthony Jones, who's a rheumatologist and a pain scientist with us in Manchester, has shown clear brain activation of pain systems within the brain in patients with classical codified fibromyalgia. Next slide, please. And again, in fibromyalgia, you can show increased neural activity if, for example, you stimulate the nerve in the leg, or even, and a very nice model actually, is dental pain if you stimulate interalveolar nerves in a condition that we've historically believed to just be a muscle pain syndrome. And we need to do these studies, obviously, in Becker. Next slide, please. So I think in essence, and I've been keen not to speak for too long, physicians need to be more aware of pain generally in neuromuscular disease. We need to assess it better. We need to understand that particularly in Becker, it's likely to be multifactorial. So we need an MDT approach. We need physiotherapy especially. And we need to think about different ways of dealing with the pain. If there's a neural component, and I frequently try this, perhaps it might respond to neuropathic pain agents, for example, pregabalin. But as many have emphasized in chronic pain, we mustn't forget about useful treatments like acupuncture, physiotherapy, orthotics, and as I've mentioned, vertebroplasty. Next slide, please. So perhaps we actually need to do a UK study of pain in Becker. We perhaps should try and utilize pain as an outcome measure in trials, but I do think this could be problematic. We need to think about novel agents for pain. So for example, cannabis sprays are now available in multiple sclerosis. Perhaps we should think about those. And particularly when looking at the effectiveness of steroids, not just focus on the respiratory preservation, for example, in Duchenne, think about its effects on pain. We need to think more about pain in a general sense, but we definitely need to have more science to understand the mechanisms of pain and perhaps think more about central sensitization. Just a few slides there, Kate. I hope that gives a little bit of grounds for thought for what is actually a very common problem. Thank you.
Thank you, Mark. That was really interesting and very important aspect of the journey for patients with Becker. You've mentioned, and Mark mentioned about physiotherapy. Nick, physiotherapy is clearly a vital aspect of care for people living with Becker muscular dystrophy. Can you tell us why this is, and perhaps in sort of in the round, and explain sort of some of the key principles that physiotherapists follow when working with patients with Becker, and sort of building on that a little bit, how important is exercise, any kinds, but also thinking about hydrotherapy and yoga and other kinds of exercise for keeping the heart healthy, and is there ever too much that you could do? A lot of questions, sorry.
Okay, yeah, I'm just going to start, I think, with first of all, that I'm just a small cog in a very big wheel of looking after people with Becker muscular dystrophy. I don't have any slides to go with this, so you're just going to put me yabbering on for a few minutes. My role within the team is to assess people with Becker at whatever age they're presented. So from paediatric right through, and I think the oldest gentleman we had diagnosed recently was 74. He didn't know he had Becker muscular dystrophy. He'd gone through his life. He was actually in the army, played rugby, and then at the age of early 70s, he started to have some symptoms, referred to us, and he was diagnosed with Becker. So from that point of view, in terms of what we do as physiotherapists, we're going to assess people's abilities and strengths, look at their gait, and that gives us a picture, a flavour of what we can then do to help them. And as people have said, it's a very heterogeneous condition that presents in a multiple stream of different disease progression. So you get some people who, as been alluded to, that have very little musculoskeletal weakness but have a poor heart, and that's really important that we can identify those early, because they can be the exerciser, they can be the people who over-exercise but put an awful lot of strain on their heart. So that's why we work with a cardiologist. In terms of support for people with muscular dystrophy, it's a case of identifying potential problems and then trying to put things in place before they happen. And this can be quite difficult to do, and it's very experiential. So you can identify those. And lots of people don't necessarily want to hear that news. And so you have to, that's why there's a psychologist on board. That's why we work with the psychologist, so that you can actually introduce those changes in an appropriate way. When do you say to someone, you need to think about using a wheelchair? People's perception that they've got to carry on walking for as long as possible is great, but sometimes they're their own worst enemy. And some of the questions that we would ask is, do you fall? And if they say, yeah, you know, I'm not falling so much now, but the follow-up question is, are you walking so much? So if they're not walking so much, they're not putting themselves at risk of falling. So that's that preservation thing. So then they become isolated. They're not doing so much. Do you go out? No, I don't go out. Do you go out when it's windy? No, I don't go out because I'll get blown over. And that's that type of, so those are the types of interventions we're looking to provide. In terms of hydrotherapy, hydrotherapy is great. Is it available? No, it's not. And that's a real big issue across the country. We're very lucky at the orthopaedic hospital, at the hospital I work at. We've got a fantastic hydrotherapy pool. It's very cheap to use, though it's not open at the moment because of COVID, but it's accessible as long as you live within, I don't know, 20, 30 mile radius of the hospital. It's very, very rare to get a good hydrotherapy pool sessions. In terms of other exercise, yes, exercise is great. I'm a huge advocate of exercise, as everyone knows. And that's always the question, is how much is good, how much is too much bad? Yes, too much is bad, and that's too much is bad for everyone. Even in a normal population, too much exercise is bad. We don't know. We simply don't know. There's been some research on exercise in neuromuscular conditions and in Becker. It's not great evidence. There is evidence that it makes a difference. Does it make enough difference? Possibly. How much? I've no idea. And I'll be perfectly honest, when I prescribe exercise, I say to people, I don't really know how much is enough. I don't know if it's going to be too much or too little. I think what's important is people do activity that they enjoy, and whether we use exercise is the wrong word. Activity. Do you just want to go out and do some activity? Go for a walk. Get an exercise bike. I've never heard of anyone falling off an exercise bike at home. So it's a great way of keeping up a little bit of cardiovascular fitness, a little bit of muscular fitness. Swimming's good. It's getting in and out of public pools. That's always a problem. Yes, floor-based yoga, floor-based Pilates is good. In terms of weights, probably with extreme caution, and they've got to be lightweights and done with a few repetitions. We're not looking to build strength. We're not looking to build hypertrophy, make bigger muscles. What we're doing is just trying to preserve what's there for longer. And with the cardiac problem, I think that the most important thing people need to do is go to see a cardiologist, get regular echoes to make sure that their heart is coping with the exercise that's being prescribed. Was there another question? I can't remember now. No, I think, I mean, like, it's open now. If people want to ask further questions, I'm more than happy to sit around and answer them. So I
mean, people should keep asking questions. If we don't get to answer all of them now live, we will respond to as many as we can afterwards and put the answers on our website.
I just want to say one more thing, sorry, and then this sort of carries on from Mark's point of view and pain. Yeah, pain's a big problem with Becker and dystrophies in particular. Are we good at treating pain? No, we're not. We try to look at what's called the BPS model, which is a biopsychosocial model. So the biology is only one small part of it. And sometimes the bigger part that needs to be addressed is the psychosocial part. So people's feelings about pain and how it affects their social life can be more important than the actual biology of the pain. And the other thing that Mark alluded to was orthotics and gait analysis. We're very lucky at the Oswestry. We've got a fantastic gait lab. We can put people through the gait lab and have them analyse the way that they walk, and then we can look at using orthotics, splints and braces to help them walk. I think it's very difficult to do that because of the fine balance that people adopt as their muscles get weaker when they're walking with Becker. That if you try and do something to correct something, you often make things worse. So if it ain't broke, don't fix it, is my sort of take on that. Sorry, that's it now. Sorry.
Thank you. Wilma, I'd like to move to you now to sort of ask you what the role of the care advisor is and how you support people living with Becker muscular dystrophy.
Okay, thank you for inviting me along today. It's been very informative so far, and I've enjoyed it thoroughly. My role is mainly emotional psychological support, and normally at the point of diagnosis, the team I work with is Ian Horrocks and Maria Ferrugia in Glasgow, and they always make sure that I'm there at that very first appointment. They won't see a patient without me being there, which is really good. So it enables me to make that connection with the families and the young person at that point. And from there on, I don't do a lot at the clinic at that point. I would rather see them at home. I arrange to follow them up at home after that first clinic appointment and look at how the diagnosis has affected them and where they are, what their understanding of the diagnosis is, and what information do they want. I try and sort of advise them not to Google things, but of course everybody does. But I always direct them to MDUK website, because we know there that's going to be the proper information and research that's up to date. On a home visit, a lot of the time is really supporting the parents at that point, because it'll be a young person that's been diagnosed, usually probably 5, 6-ish. They would come to clinic. So really my information is about supporting the families. I'm keeping this brief, by the way, because I know we're running out of time. A lot of it is looking at the whole situation, holistic approach as always. I work with a fantastic team in Glasgow. I've got access to physio, which is crucial, OT, physiotherapy, all the other agencies. And a lot of it, as I said, is emotional psychological support. And if I'm getting without an area that I'm comfortable with, that I feel is out with my boundaries, I can then refer on to the CAMS team. And we've got psychology services at the hospital. And I'm sort of the in-between person, because quite often the waiting list for seeing somebody in psychology is quite long. So I'm a kind of stopgap person and try and keep them ticking over until they get the professionals that they need to see. My role sort of jumps in and out throughout the whole transition. I go from adults, I cover adults and children across the west of Scotland. So I start off at the point of diagnosis, and then at points of change when they have to maybe change to a different school, I go in and do education to the school, maybe when they're losing their mobility as well, then it's a big step, as everybody's referred to earlier on, moving into a wheelchair, and how the fatigue will improve greatly, and it's really trying to help them at that point as well. And then mainstream education, we encourage mainstream education for all our young people with muscle conditions, and then access to work. So I'm just going through the whole gamut. It's my role goes right through, so it's about letters of support, DLA appeals, housing support, housing appeals, all these things, and referral to other services, and being that liaison and that link, and making sure that they've got the referrals to the right people to ensure that they can live as independently as possible. That's what we're trying to do as a team, and I'm very lucky to be part of a fantastic team in Glasgow. So that's just a very brief overview of what my role is. Any questions, I'm more than happy to answer.
Thank you, Wilma. That's fantastic. Thank you. David, moving to you now. Obviously, you're the biggest expert on the panel, really, because you are the person who lives with the condition that we've been talking about. So could you tell us a bit about how that is for you? And I mean, presumably, have you had to make adaptations to your home? Perhaps you could talk a little bit about that as well.
Well, basically, my story started when I was a toddler. I was walking up on my tiptoes, and I was taken to the Cumberland Infirmary in Carlisle, and they didn't have a clue what was wrong with us, basically. So I got sent over to Newcastle under the care of, well, Kate Bushby, actually. I think someone just mentioned it previously. And I got a muscle biopsy, and I was diagnosed from there. And I've been involved pretty much since then, really. My current role, however, is part of the Scottish Council. We help make decisions on fundraising activities, advocacy, advice. It's been quite an interesting role to be part of, seeing the ins and outs of the charity and getting the knowledge on the fundraising activities and such like. Obviously, it's been curtailed with what's happened with the virus and everything. I think I've been asked on this panel today as well because I've got the practical knowledge of having the condition. I'm going through what some of the older guys have gone through, and the younger people, I've gone through what they're going to go through. I've gone through all the issues with benefits, orthotics, physio. You name it, any issue, I've gone through it at some point or other. Using the advocacy service, I was struggling to get a suitable home. They helped me get home with a ramp access, wet room, so I'm all prepared for when I become a full-time wheelchair user. So I wasn't quite prepared for this, to be honest, but
no, it's also very personal because everyone else is talking about things about other people. We're saying, how is it for you? Yeah, no, it's a very difficult thing. Am I correct in thinking that you were also part of some trial? Was that through Newcastle or?
When I was younger, I was going to go on a trial through the Royal Victoria in Newcastle, but that's when they actually diagnosed us with cardiomyopathy instead. So I actually only found out I had that by accident because of going on the trial.
Gosh.
So, so I never got to partake in it in the end because they found the underlying heart condition.
Right.
But,
actually, experience that sometimes in screening for being part of trials that can show that you may not be suitable for that particular trial, because as Thomas showed in his slides at the beginning, there is this sort of ideal, if you like, within a trial that you've got all of the nice Granny Smith apples rather than the whole mix of all the different kinds of potential apples that you've got that exist. So yeah, that was been a bit of a miserable experience, I guess, not being part of the trial, but an important discovery, I guess, for you personally to find that out. So
well, yeah. Thanks a lot. And if anyone has any questions, feel free to contact anybody and they can forward your details on to me, and I'm happy to help.
Wonderful.
So,
thank you very much.
Thank you.
Great. That's great. Now, you mentioned the dreaded COVID word, and I just wonder whether maybe if I can just quickly ask Mark and Nick and Thomas, how is COVID affecting the services that you are providing to people at the moment?
It's having an enormous effect, to be honest, Kate. You know, face-to-face clinics at the moment are very restricted. And that's, of course, because we don't yet have staff testing. By that, I mean, we really do need to have weekly testing of medics, physiotherapists, nurses, to know who might be carrying it without symptoms, so that we might prevent giving it to our patients. I suppose they might give it to us, but I think I'm more of a risk than anyone else here going to the intensive care units as I do regularly. And let me say on a positive note about shielding, we have not yet, I hope to God we don't, lost a neuromuscular patient in the northwest of England. And that can't be because of great medical care, because patients haven't been having care other than a few phone calls. It's because patients have been so sensible and shielding. So I commend patients for what they've done, even the social isolation that obviously COVID causes. Thinking in the future, we need to think about different ways of working. We need to think about video consultations. We need to think about more phone call support. We need to be more flexible in the way that we help patients. And the other thing that we've certainly been thinking of, and they certainly have in Newcastle as well, been thinking about, is how do we get important metrics? By that, I mean, how do we, for example, keep an eye on lung function? When you'll be aware that doing a vital capacity, blowing into that tube is definitely an aerosol generating procedure. And as Nick will know, and we've been talking with Tracy Willis in Oswestry about this also, there are now very fancy vital capacity machines that you can actually get linked via your mobile on Bluetooth that show you a flow volume loop. So if we want to look for respiratory problems, there may be new novel technology ways to get around COVID 1, 2, 3, 4, 5 spikes. I don't know how many. I hope not too many more. So those are the points I would make about COVID. But I think the most important point, coming to Wilma's comment, is that patients need support at home because they may not be seeing their medics. So we need to reach out more to our patients, ever more so.
Thank you. And I mean, Thomas, you're presumably, again, for you, it's not so straightforward to have a face-to-face visit.
Well, yes, we have partially suspended face-to-face clinics as well. And I understand that, well, I'm no longer working at the National Hospital for Neurology and Neurosurgery, but they also have a significant reduction in their activity, at least contact with them. I think Dr. Roberts has covered me 100%. I don't have much else to add. A good thing about cardiology is that it has adopted remote monitoring quite early. It's a technologically heavy specialty. For example, patients with devices, they can be monitored remotely. But we definitely need to find better ways to reach out to patients who cannot reach us. But I agree with Dr. Roberts 100%.
Nick, just a quick sort of touch on the physio side of things. I mean, obviously, again, presumably hands-on physio is not something you do very often now. if at all?
We are actually seeing patients in clinic now on a reduced number, so that's been very good. Obviously, lots of precautions taken place, wearing surgical masks, gloves, aprons. Patients are screened before they come in so that we can assess whether they have any temperature or anything. We are actually we've done 2 cardiac clinics, so we've actually seen patients and done echocardiograms on them, which has been a great bonus because the waiting list for those is quite enormous now. In terms of, as Mark said, the way forward, we did do a lot of video consultations, which was actually quite stressful from the physiotherapy side of things, trying to get people to do a task at home so you could try and assess their functional ability and then prescribe an exercise or something like that that would help them was certainly a challenge, but one that I think we can take forward. It's not as good as seeing people face to face, but it's a need, and it's been an experience. Let's put it that way and just leave it at that.
Yeah, no, I can understand. There's a really interesting question.
May I make a comment? I forgot something that's quite important from our end. What we were referring so far is elective services. There has been an observed increase in cardiac related problems during the COVID isolation era, and a reason for that is that people were too scared to attend the emergency services. Now, obviously, this is in a slightly different setting, different population. We're talking about heart attacks and that. But if any patient experiences symptoms that are truly severe, they should raise them with a doctor or even with the attend A&E. Okay, we shouldn't make a note that, okay, COVID is out there, but it's much worse to stay at home and try to get through your symptoms rather than seeking medical assistance, because we have seen a surge in cardiology problems just because people are too scared to reach out and ask for help.
Thank you. Yeah, that is an important point. Thank you. There's a really great question here about someone saying about the in their experience, the emotional impact of this condition contributes to people's lack of involvement with medical services. Do you have any suggestions how to get people involved without actually sort of frightening them and scaring them? Wilma, maybe if I could perhaps come to you first and then take it from there.
It's about trying to gain their confidence and their trust, and explaining that we're here to offer the support and it is as safe as possible. But there has been a huge rise in cases that I've been dealing with because of the anxiety component. With COVID being around, that's just exacerbated already the family's issues with anxiety dealing with any muscle conditions. So there's a huge increase in our workload, especially mine at the hospital. But it's about trying to reassure the person, the family, that we're there for them. It'll be as safe as possible if they have to come into the hospital and everything. We wear PPE anyway now all the time, even in home visits, which makes your job very difficult. Trying to be empathic through a whole lot of PPE, but it's what we have to do. You're muted, Kate.
Thank you. It had to happen at some point. And what about those patients who perhaps have not engaged with medical services? Perhaps they've transitioned to adult and then they've kind of maybe not been as engaged with the medical services as they could have been. How do families, sort of, people in their late 20s, early 30s even, encourage them to start actually going to see a doctor? Have you got any tips for that?
Just about being honest with them and saying, the benefits of seeing a doctor is really important, and hopefully they will engage. Quite often I get referrals from other agencies to say they've had a consultation with a young person or an older person, and they're wondering where they can get support. They're looking for advice. So again, because I'm kind of well established now in the service, I get a lot of referrals off the cuff like that. So again, it's for me to engage with them and try and encourage them to seek the proper help and support, and that's partly my role as well.
Great, thank you. Well, that's a great tip there. And again, I guess if people are concerned, they can contact MDUK, and we can put people in touch with care advisors around the country. I think that would be a way to move forward. I am mindful of time, that we have already overrun, and we have a lot of questions still on that we haven't answered, and we won't get to all of them today live, but we will reach out to the panel members with the questions to ask if they can provide us with some answers that we will put onto our website, so people will be able to find some answers out after this event. So I think that really with that, I would like to end this event now by saying thank you so much to the panel, to Federica, to Nick, to David, to Thomas, to Wilma, and to Mark. It's been an absolutely fascinating session. Thank you very, very much for your time. Thank you also to all the participants. It's been great, and thank you for your engagement with us. I'm sorry we haven't got to answer all of the questions today, but as I say, we will do so. This session has been recorded and will be uploaded onto our YouTube channel in the fullness of time, probably probably early next week. Just leaves for me to thank the panel, to thank Sarepta again for supporting the Muscles Matters online seminar series through their sponsorship, and just wish everyone a fantastic day. Thank you so much for your time. Thank you for engaging with us. Have a great weekend, and we look forward to seeing you again soon. Thanks everyone. Goodbye.